Clinical negligence is a broad topic. Obviously it falls within the parameters of claims in tort negligence for damages for personal injury, so that, for example, the personal injury limitation provisions apply. Within that context, however, it also falls within the umbrella of claims for damages arising out of professional negligence. There are clearly many aspects in which such litigation follows the pattern of any standard personal injury claim. There is, of course, a separate pre-action protocol. However, there are some aspects of a standard personal injury claim which need to be looked at differently in the context of a clinical negligence claim. If we imagine a woman who has been suffering from some symptoms and goes to see her general practitioner, the symptoms are of altered bowel habit, and the GP feels that investigation is required, in particular to rule out the possibility of cancer. The patient, we'll call her Mrs. Jones, is referred to a consultant whom she sees at hospital. The consultant reads the letter she has from the general practitioner, setting out the symptoms, and Mrs. Jones confirms that those are the symptoms that she's been suffering from during that consultation. However, the consultant doesn't examine Mrs. Jones. We'll call the consultant Mr. Smith. He tells her that she needs to undergo a colonoscopy, and an appointment is booked for that procedure. The procedure is undertaken, but at a point where there is a kink in the bowel, the scope perforates Mrs. Jones' bowel. The perforation was identified immediately, and Mrs. Jones was moved into theatre, given a general anaesthetic, and a laparotomy was performed. The bowel was repaired, and there was no need for any further or more extensive surgery. Following her recovery, Mrs. Jones consults solicitors, and she brings a claim in respect of that perforation and the consequent need for surgery. That includes the need for the operation, the laparotomy, the scarring that she's been left with in consequence, and the fact that for a period of time she suffered pain and had to alter what she ate in order to accommodate her improving symptoms. Mrs. Jones' pleaded case sets out in essence the following allegations. Firstly, that Mr. Smith failed to warn her of the risk of perforation. The risk is said to be between 1 and 2%. Secondly, that Mr. Smith failed to examine her or take a proper history from her. It's said in the pleading that if he'd done that, he would have identified that she was a very small, thin woman and a heavy smoker. Those factors would increase the risk of perforation of the bowel to about 3%. Thirdly, it's pleaded that Mr. Smith failed to discuss with her an alternative form of investigation, namely a CT scan. And finally, that he failed to exercise reasonable skill and care, and that's what caused the perforation. Now imagine that the matter goes to trial. At trial, the judge finds that Mr. Smith did fail to warn Mrs. Jones of the risk of perforation, and the judge goes on to find that that failure fell below the standard of care. The first question then is, how did the judge reach that conclusion? So again, following a trial, imagine that there has been expert evidence given, and on this point there was no dispute about the failure. The experts called for each side agreed on this issue that a warning should have been given, and that in failing to warn of the risk, Mr. Smith was not acting in accordance with a practice adopted as proper by a responsible body of medical men. That's what's called the Bolam test, and that follows on from the case in 1957 of Bolam and Frean Hospital Management Committee. I'm asked, at what point will a doctor expose himself or herself to liability when prescribing a drug which is beginning to demonstrate unanticipated side effects? I think that the answer to that probably lies on the information about it beginning to demonstrate unanticipated side effects. If there have been official newsletters and publications being put out by the relevant professional bodies, they usually will include a notice to stop prescribing a drug. If it's a matter that's contained in various letters to newspapers, I've been prescribed this drug and it's making my hair go green, then I doubt very much if stopping prescribing a drug that is otherwise of value clinically would expose a doctor to liability. I think the information would have to come from a professional body or from the drug company itself. And as soon as that happens, then I think the doctor would clearly expose himself or herself to liability. Having said that, if the doctor had direct experience with a particular patient of a side effect, it would be important to discuss the side effect and to consider the upside and the downside of the treatment and the side effect. If it was helping with a serious disease and the patient's hair was going green, maybe the patient would put up with it. If it was risking heart failure, then clearly the doctor would be negligent in not stopping that. I'm asked by Michael Benson, could you outline the basic rules on estimating damages in clinical negligence cases? The estimation of damages in clinical negligence cases follows almost exactly the same principles in any personal injury case. So you're going to be looking at general damages under the heading of pain, suffering and loss of immunity. It's always important to remember that will follow the actual consequences of the clinical negligence, so that if, for example, you've got a condition, you're going to go into hospital anyway, you're going to have an operation, you're going to have a scar, you're going to have a period of recovery, then you're not going to be compensated for those heads. What you're going to be compensated for is any extra surgery, extra scarring, extra pain, and so on in consequence of that. So general damages for pain, suffering, loss of immunity, and then again the usual heads of special damage that you would get in any personal injury claim, subject always to this caveat that there probably would have been some loss of earnings or some financial losses or the need for some help or care in consequence of whatever was the original medical problem.